Okay, thank you for inviting me to speak. So today I'll be presenting a clinical psychologist perspective on FCD and how what we know about FCD informs psychological treatment, as well as some personal views based on my experience. So what do patients say about their difficulties? These are some participant quotes from Norman and I and colleagues at the FCD trial. And as part of the trial, some of the participants were interviewed to explore the challenges of living with FCD. And the quotes, I think, highlight the unseen nature of the condition, both in terms of the symptoms themselves, but also in how the patients experience treatment within the NHS. And I wonder whether does the experience of feeling unseen and maybe disbelieved play a part in the increase of focus on the cognitive symptoms and almost needing to prove their experiences of difficulties. And these quotes also highlight the losses that people with FCD can experience, including reduced efficiency at work, reduced social connections, reduced self-confidence, and a sense of isolation. But before I talk about FCD more, I'd like to highlight, as others have done, how ubiquitous cognitive symptoms are. And I think particularly cognitive symptoms are often more prominent at times of stress and are in a way a warning sign that you are overburdened. And I think this is an important aspect to consider, as anyone who's worked with patients with FCD will have observed that they're generally high-functioning and busy individuals, often not particularly in touch with their emotions. Therefore, in thinking about the development of FCD, it's reasonable to consider that someone who's developed FCD may have done so at a time that they were overly stressed, but without necessarily realizing that they were. And as you've heard from others, that it can be part of other conditions. But I think just to highlight also, within a medical legal context, it's possible that people can exaggerate or feign cognitive symptoms for financial gain. So I'm now going to focus on FCD, where cognitive symptoms are the primary concern, so rather than functional cognitive symptoms. And I think that the sort of key difference there is that focus on the symptoms themselves, and also the focus on kind of beliefs about causation that is, present when you present with someone with FCD. So I'm going to whiz through the mechanistic models. Other people have mentioned them already. But published models include this one by Tiago Teodoro and colleagues, and they highlight the role of excessive or misdirected attention, unhelpful illness beliefs, effortful cognitive processing can play in the impairment of cognitive performance. Rowan Boehm and colleagues published this one focused on metacognition. And in line with Tiago's model, Laura McWhirter and Alan Carson have published this model focusing on how behaviours connected to beliefs regarding cognitive performance and reduced attentional capacity can contribute to cognitive failures. Noah Silverberg and Beth Rush have put together this cognitive behavioural model, which highlights catastrophic interpretations and hypervigilance of perceived cognitive failures and avoidance behaviour as key parts of the condition. And you will have heard from Veronica already on their kind of paper looking at how acute precipitating events can lead to cognitive symptoms that a person doesn't habituate to over time. So I think that the models highlight that an acute event such as COVID or a head injury are common, and that illness beliefs regarding the cause of symptoms can be key sources of anxiety and maintenance of the disorder. And the idea of memory perfectionism and how this can contribute unhelpfully to illness beliefs. It has been proposed that impaired metacognition is a factor in FCD, but the literature is mixed on this. There's been a recent review published by Anna Sednika and colleagues that's worth looking at if you're interested. Patients with FCD appear to be hypervigilant to and selectively attend to cognitive failures, as well as having catastrophic interpretations of minor lapses. And patients develop predictions of cognitive failure, both with and without their awareness, and this interferes with automatic cognitive activity, which leads to effortful cognitive activity, reducing attention on a task, and makes cognitive failures more likely. And this then reinforces negative beliefs regarding cognitive abilities. And behaviours that people with FCD engage in as an attempt to manage their difficulties, such as note writing, checking, reassurance seeking, and avoidance of associated situations, contribute to the disruption of automatic cognitive activity and can also reduce attention on a task, making cognitive failure more likely. In considering what might not be captured by the models, I think it's hard to capture the intensity of focus on overvalued ideas that patients with FCD can have. I mean, I'm sure you've all met someone with FCD where you just cannot shift them. They're convinced it's the COVID vaccination, they're convinced, that they've got a significant head injury, even though there's loads of evidence that they don't. And it's really, really hard to engage someone in treatment when they're kind of 100% sure that this is the reason for their difficulties. And for some patients, I think their self-esteem is really linked to their cognitive performance, which really increases that threat of the symptoms. And when I see someone with FCD, as with FND generally, I always consider whether by focusing on their cognitive symptoms, what does this enable them not to focus on? And in therapy, I will explore with the patient whether there's an unacknowledged or unseen impact of other issues or events in their life. So moving on to treatment approaches, Veronica gave a really good overview of them, and these are recent papers published. And it's really been a kind of explosion of papers, actually, considering sort of 5 years ago there was barely anything. And I've also listed there some 2 papers from the post-mild TBI literature, given that we know FCD can develop after a mild head injury. And all of these treatments can be considered to fall under the broad category of a cognitive behavioural therapy intervention. I mean, CBT interventions can include CBT therapy in line with kind of Aaron Beck's original ideas, or newer iterations which include therapies like ACT, dialectical behavioural therapy, mindfulness-based cognitive therapy. And in my view, this would be a broad overview of psychological treatment for FCD, with some elements not necessarily needed. Firstly, education regarding memory. And FCD can help to reduce the threat of the symptoms and increase a patient's understanding. Secondly, focusing on behaviour modification, using traditional CBT approaches focused on reducing safety behaviours and avoidances, or by using so-called third-wave CBT ideas, like those within ACT, to help someone focus on increasing value-driven behaviour. Thirdly, focusing on a patient's thoughts about their difficulties, either by using cognitive restructuring, a traditional part of CBT, or more third-wave CBT ideas like introducing mindfulness practices and examining a patient's relationship to their thoughts. Fourthly, helping a patient to improve their relationship with their body by recognizing any emotion-body links and possibly teaching relaxation strategies. And finally, for some patients, more in-depth therapy is required, and it can be helpful to look at their broader life context and current relationships, examine the lead up to symptoms, and explore relevant early experiences. But the above could be an overview of psychological treatment for any FND presentation. And really what is different is the specific education regarding FCD. So I guess it's kind of how to get someone into therapy is the first step. So now I'm going to cover a treatment example. So this was a patient I saw who was a married man with children in his 50s with a busy and demanding job. He was involved in a public transportation accident. He had experienced no loss of consciousness. His MRI scan was normal. He'd seen a few doctors, and there was consensus it was FCD. And after the accident, he originally felt like the left-hand side of his head was numb, although this had lessened over time. And in terms of his memory, he reported that he would lose the thread of conversation, forget things, and pre-morbidly, he described himself as having a memory of an elephant. And he was experiencing no depression or PTSD. So these are his outcome measures at the beginning of therapy, and you can see that they're all subclinical. And he described feeling more anxious compared to pre-accident, but anxiety wasn't dominating his life. He had a little transport-related anxiety, but no avoidance of using it. And in terms of PTSD symptoms, he had no flashbacks or nightmares, but he did startle easily, and that's reflected on the hyperarousal subscale score on the PCL-5, which is a PTSD measure. So in therapy, it was sort of in 2 halves, really. The first half, sort of 5 sessions on education and cognitive behavioural therapy, so looking at a model of how FCD develops, common maintenance cycles, education regarding memory and normal forgetting. He completed kind of CBT diaries after perceived or anticipated cognitive failures, so he looked at kind of his thoughts, his feelings, his body sensations, his behaviour. And we looked at kind of common cycles that he would get into. And he noticed he was frequently caught up in thoughts regarding how he needs to remember, and that then attention was away from the information he did actually want to remember. We identified unhelpful thinking styles like catastrophizing, black and white thinking, and we also looked at his daily routine. He filled an activity diary, and he made more time for kind of valued activities. And we looked at relaxation strategies. So before I move on to the second part of the therapy, the second part was EMDR. And just briefly to anyone who doesn't know, it's an evidence-based treatment for PTSD. And it's actually a memory-based treatment, so it's designed to reduce disturbance associated with memories and images, not just those associated with PTSD. And its use for physical conditions is growing. And as Niels mentioned, I've recently completed a feasibilities trial looking at EMDR for FCD. So within that trial, we recruited 50 participants with functional seizures and/or functional motor symptoms, and we demonstrated feasibility as well as having promising signs of efficacy. And within the trial, participants chose 2 FCD symptoms to rate at the start of the study. And I think interestingly, I just bring this up today, 32% of participants chose to rate cognitive symptoms. So that was not the group that we were recruiting, but nonetheless, nearly a third of participants chose to rate their cognitive symptoms as one of their 2 symptoms. And then even though we didn't focus on cognitive symptoms at all during the EMDR therapy, participants in the EMDR group who'd chosen to rate cognitive symptoms rated that these symptoms were causing them less distress, that they were less severe, and causing them less interference, and they were less preoccupied with them at the end of the trial. So I think that's interesting. And his EMDR, he had 6 sessions of EMDR. The first target was his memory of the accident. And within EMDR, you do a standardized assessment, and part of that assessment is to rate somebody's disturbance associated with the memory. So on a scale of 0 to 10, where 0 is no disturbance or neutral, and 10 is the highest disturbance you can imagine, he rated his disturbance as 8 out of 10, and that reduced to 0. And at the end, he was kind of left with remaining physical sensations, where the right-hand side of his brain felt bigger, and his left-hand side of his brain felt shrunken. So then we targeted an image of his head, and the disturbance associated with that image was 5 out of 10. And it was really interesting processing. So during processing, he experienced the sensation of fluid moving from one hemisphere to the other. It was quite sort of imagery-based, spontaneous, his imagery. And the left-hand side of his head felt fully inflated, and there was no tension in his body like there used to be. So the treatment outcome, his memory improved. Any forgetfulness was not bothering him as much as it used to. The numbness in his head was subtler at times. The right-hand side of his head felt bigger than the left-hand side, but it was more balanced overall. And he reflected that the earlier sessions helped him to understand his symptoms more and feel less anxious about them. And the EMDR sessions, in his words, helped get the emotion out in connection to the accident. And these were his pre-post measures, so almost down to 0, but they were very low to begin with. So I think the original title of my talk was What's Missing, and that was before I wrote the presentation. And I sort of looked at all the research. I was like, actually, we're not doing too badly, because there has been lots of research recently, so we have a much better understanding of how FCD develops and how it's maintained. And there's a few pilot studies sort of demonstrating benefit for CBT interventions. And I think it sort of shows that psychological treatment can be delivered at a sort of low intensity level. But I do think that some patients require a kind of higher intensity, sort of individual formulation-based psychological therapy, and that this can help to increase engagement, enhance emotional processing, explore unacknowledged or unnoticed issues or events that may be connected to their FCD. Okay.